So my topic is surprises after cataract surgery in eyes with diabetic retinopathy. We are all aware that in any patient who's going in for a cataract surgery with underlying diabetic retinopathy, there are two or three things that we need to do. One is to see whether the defective vision is primarily due to the cataract or primarily due to the diabetic retinopathy. I think this is very, very important. And this is possible unless and until the cataract is very significant and we are not able to make any proper assessment of the posterior segment. Otherwise, today, I think most people operate on cataracts quite early, and therefore, I think in most of the cases, so it's very important. So some of the things that have been told already, like the OCT, careful examination of the optic disc is very important in diabetic patients with retinopathy because previous history of non-arthritic optic neuropathy is one of the very common causes of unexplained visual loss in patients who undergo cataract surgery in underlying diabetic retinopathy. So having said that, I'll just share with you some 3 or 4 cases, and with that we can just give you some messages. So these are all patients that have been treated in our hospital over the course of the last 8 to 10 years, and I think I made this presentation in the AIOS in the previous years also. So this is a very old case, but why I should so old cases is these are patients with long-term follow-up who have been under our care for many, many years. So this gentleman came with a visual acuity of 618, 624, known diabetic on treatment. This is the fundus photograph, and he also underwent. So whenever we see diabetic retinopathy in patients with cataract surgery and the media is reasonably good, it would be advisable to complete all investigations prior to cataract surgery, including OCT and, if necessary, fundus fluorescein angiography, because you will know whether he has got a treatable retinopathy or he has got a non-treatable retinopathy. That is a retinopathy that does not require any treatment. So this patient has got something like a CSME, suspected CSME in the right eye. So the patient underwent multiple injections. Now you can see the visual acuity has further deteriorated because of the advancement of the cataract. And at that point these are all very old cases. That's why we have given bevacizumab in some of these patients. So at the time of cataract surgery, we also give 1 shot of bevacizumab because that is the protocol in our hospital, because cataract causes intraocular inflammation and most patients have an exacerbation of the diabetic macular edema. So it would be advisable, even though the edema is very minimal, to give 1 shot of anti-VEGF at the time of the cataract surgery. So this patient underwent multiple injections after cataract surgery. One need to understand that unfortunately, some cases of diabetic macular edema behave in a very, very difficult way after cataract surgery. There is significant worsening, as you can see in this particular case. And this patient again was treated about 10 to 12 years ago when Osutex was not there, and that's why he received Triamcinolone. The reason why we gave Triamcinolone is because of the significant edema, serious macular detachment, systolic changes. And of course, with 1 dose, he did improve. And if you see the initial picture, now if you see this sort of picture, you know that these are patients who like to have a lot of microaneurysms, and therefore you do the fluorescein angiography. And based after the once edemas, let's give perifoveal laser photocoagulation to the microaneurysm. This is a must, especially in patients who have got cercinates. They do extremely well with laser photocoagulation. But unfortunately, this patient again had a recurrence and again received 1 more shot of triamcinolone. And again did the fluorescein angiography, and residual microaneurysms were treated. So the take-home message is pre-existing DME can worsen following cataract surgery. Although you might have treated this DME prior to the cataract surgery, there's a possibility of worsening, and therefore you need to keep this in mind when you hand these patients. Now this is a patient who had a center-sparing DME. You can see the red color that's not involving the fovea. So it was a center-sparing CSME with a normal fovea, and therefore this patient in those days underwent just a phaco. But unfortunately, again, immediately after phacoemulsification, within 6 to 8 weeks itself, the patient came with a drop in vision, and there is significant CSME. And the patient again underwent triamcinolone injection, and again fundus fluorescein angiography was done. And this patient again received perifoveal laser photocoagulation, because these types of CSME where you see cercinates and hard exudates, focal microaneurysms will be there, and they respond very well to focal laser photocoagulation also. So this patient had 2 sittings of perifoveal laser photocoagulation with multiple sittings of anti-VEGF and triamcinolone 1 or 2 doses, and with that sort of an intensive treatment. Now this is very, very important. These patients have to be treated intensively, and once you do that, in many of these cases you do see significant improvement and stabilization of vision and also stabilization of the diabetic macular edema. Now this patient, after multiple injections, multiple dose of focal laser to microneurysms, finally his macula settled, and I have a follow-up of about 8-10 years. He still remains quite stable now with a reasonably good visual acuity of 6/18 and 6. That means his diabetes is under control, and unfortunately the cataract surgery resulted in worsening of the diabetic retinopathy. Now in the left eye, I changed the treatment. Since the right eye behaves so differently, I thought, okay, left eye, let me treat the DME again prior to surgery. But in spite of treating the DME prior to surgery, in the left eye also the behavior was worsening of the DME after cataract surgery, and a similar treatment was given to the left eye, and he finally responded with a reasonably good visual acuity of 624, 636. You can see the left eye, how it was immediately after the cataract on the top side, and on the bottom side you can see the hard X-rays have significantly decreased. Therefore, I would like to say that the center sparing DME also in patients with underlying cataract should not be taken lightly and should be intervened prior to surgery. Probably a focal laser photocoagulation can be given to the microneurysms prior to surgery if it's possible, and preoperative OCT, of course, is important, and immediate postoperative retinal examination is important. Now, the third case is indeed a very interesting case. This again is from our own hospital. This patient was treated in the community section. This patient underwent cataract surgery in the right eye and left eye in a short gap, and with diabetes of 12 years duration. Visual acuity fantastic, 6/6. But she had moderate non-proliferative diabetic retinopathy, but unfortunately the patient was not referred to the retina clinic. The patient came back even after a month or so. Imagine, the patient has been careful. I mean, the patient probably had slight blurring of vision. Again, it was seen in the outpatient department. Everything has been documented in the chart, severe NPDR, but no color photo, no fundus fluorescein angiography, and finally, July 2020, within a matter of 3 months, the patient comes with a drop in vision, with a dense vitreous hemorrhage in the right eye, with a visual acuity of CF 2 meter. So what we learned from this particular case is, number one, it was not managed properly. So once you see severe non-proliferative diabetic retinopathy, it's important to at least send it to the retina clinic, or at least do a fundus fluorescein angiography to see whether there are subtle areas of retinal neovascularization, and give adequate laser photocoagulation immediately. So this could have been a preventable situation, and you should always remember that even ischemic processes do worsen with after cataract surgery, and we have seen cases even of proliferative diabetic retinopathy who have had adequate laser photocoagulation, and where we expect good visual acuity, who improve initially, but unfortunately posterior vitreous separation starts after cataract surgery, and that causes a tractional retinal detachment and worsening of visual acuity. So you can see the color photo, and you can see the fundus fluorescein angiogram. There is a definite disc neovascularization, and although this patient was treated with laser, etc., visual acuity in both the eyes deteriorated, and there was a worsening of the retinopathy rapidly in both the eyes, requiring surgical intervention. So possibly, in spite of laser, this might have happened, but nonetheless, this probably could have been prevented to a certain extent if we had made an early diagnosis. The last complication which we notice in patients with diabetic retinopathy and cataract surgery is neovascular glaucoma. Unfortunately, I could not track any particular treated case from a hospital, but one should always remember that some of these patients with proliferative diabetic retinopathy who have dense cataract, you do a cataract surgery because VEGF levels increase after cataract surgery. VEGF levels increase in the anterior chamber, and therefore they come to you with neovascularization of the iris and neovascular glaucoma. We have had many, many cases like that, and these cases have to be treated early and aggressively. And if you do that, some of these patients do regain reasonably good visual acuity. Thank you all for your kind attention.